you can have intraoperative problems from the incision. If your scleral wound is not too oblique, it would leak in the postoperative period. If there is a gauge mismatch, in the sense that sometimes we enlarge the sclerotomy to remove a foreign body and then subsequently carry on the surgery with the same 23 instrument that we use for vitrectomy. In those cases, you would have a continuously leaking sclerotomy, which would create problems for you both on the IOP front and by creating bubbles and impairing your view. If there is a tunnel, if the tunnel is too short, you would have a postoperative leak and a hypotony. You sometimes have subconjunctival tamponade also. If you are in the wrong plane, especially with your infusion cannula, it can go into the subretinal plane and cause retinal detachment. It can go into the choroid and cause a choroidal detachment. So always visualize the tip of the trocar or your infusion cannula very clearly before you switch on any infusion. A lot of times, even when you visualize the tip of the trocar clearly in the vitreous cavity, during surgery and during manipulation, especially scleral indentation, your cannula can slip into the subretinal space. Now, this is a case of a combined RD that in a diabetic that was being operated upon, and the surgeon notices that there is a slowly rising mound in the inferotemporal quadrant. That was because the 25 gauge cannula had slipped into the subretinal space. Now, the treatment for that is to stop infusion. You have to remove sometimes the cannula. What you can do is, when you reintroduce it, you fix the infusion into another of your cannula, which is very well in the vitreous cavity. And when you reintroduce your infusion cannula in the inferotemporal quadrant, go straight rather than going in the oblique fashion, so that the risk of being in the choroid or being in the subretinal space is minimized. So here you see that the surgeon now is going perpendicular to the sclera, direct, so that the next time around this does not happen. So once again you have to confirm that your tip is very well into the vitreous cavity. Once you have confirmed that, you switch on the infusion and carry on with the case. If you have created a retinal detachment, you may have to drain the retinal subretinal fluid. If you have created a choroidal detachment, you will have to drain that as well, if it is significant in size. In this particular case, the subretinal fluid was drained at the end of surgery from a existing retinotomy. If your incision sites, whether it be a 20 gauge surgery or your cannula in MIVS, if they are not guarded, either walled or left without plugs for too long, you can have retina jumping in off retina cases. You can have retinal incarceration, you can have intraoperative retinal tears, and you can have intraoperative turbulence in your PFCL bubble and disturbing your blood that is settled at the posterior pole. This is a endoscopic picture of a vitreous getting incarcerated in the sclerotomy site. Here you can see a retina getting incarcerated, and because of that, a retinal break has formed here and here. So this risk is much more frequent if you have a exchange of instruments in a off retina case, a frequent exchange of instruments before you remove the vitreous totally from the sclerotomy site. So when you start off, you first remove the vitreous at the sclerotomy site. Now, intraoperative leaks can happen when you have a large sclerotomy or if you have a mismatch between the gauge. In repeat surgeries, sometimes the sclerotomy can enlarge because the adjacent sclera is thin. So initially there may be a minor irritant by causing a hampered view or a low IOP, but can lead to vitreous incarceration and retinal breaks, and therefore you need to make your ports very carefully before you embark on surgery. Now, choroidal hemorrhage can occur because of hypotony or because of a wrong placement of the cannula. Sometimes it can happen if the assistant or if you have suddenly pulled off the cannula and caused a sudden hypotony. Now, it's a devastating complication. Initial treatment is conservative, and of course, after clot liquefaction has been documented on ultrasound, you go ahead and drain the suprachoroid blood. Now, postoperative complications that can happen are hypotony, which will be dealt in far more detail by a subsequent speaker. It is more common with MIVS because they are unsutured, unguarded incisions. Wound construction and having a very low threshold for sutures. Even if you notice a little bit of leak, it's always better to err on the side of putting a suture rather than having your pride at stake and developing a hypotony or end-off later. Endophthalmitis is going to be dealt later. Subconjunctival tamponade is of mention because if you have a MIVS and your oil leaks into the subconjunctival space, it usually forms these clumps which cause chronic irritation. it is extremely difficult to remove. So if at the end of surgery, if there is even a minor leakage of oil from your sclerotomy, it is better to suture the sclerotomy. Now, suture granuloma, all of us have seen it. It is the result of biodegradable sutures that take too long. Vicryl takes about 8 weeks to dissolve. So by that time, you have continuous inflammation going on. It's a minor irritant, does not affect the outcome of your retinal surgery, but definitely disturbs the patient. Scleral thinning can happen in certain cases, especially in repeat surgeries. When you have sutured sclerotomy, sutured too tight, you can have thinning of the sclera. It is infrequently seen nowadays with the small gauge surgeries. Now, this is a serious complication, anterior hyaloid fibrovascular proliferation. It is more common with diabetic vits and less common with retinal detachment or macular hole cases, but can be seen either ways. Here, the vitreous base is invaded by fibrous or vascular tissue. It's usually difficult to diagnose, can cause recurrent vitreous hemorrhage and can cause retinal detachment as well. UBM is the best way to diagnose it, and intraoperatively endoscopy can visualize it very well. Here, you can see that there is a layer of fibrous and vascular tissue. This is a fibrovascular tissue in this is an endoscopic view. Fibrous ingrowth from the sclerotomy can also happen and then causes traction and causes retinal breaks right behind the sclerotomy. A vitreous wick in the wound is one of the most important predisposing factors. It can be innocuous. Sometimes if it has caused a retinal break, then you may have to go in and dissect it and do a full-blown VR surgery. So these were the incision-related complications. Thank you.